honest about what they are, and they're going to be very difficult to sort out, and they can be frustrating. So here's your somatic symptom and related disorders. They used to be called somatoform, so if you had abnormal sight, the DSM-4 used to call them somatoform disorders, and a lot of people still say that, and you'll also see it written out like that in notes. But this is about body complaints for the most part with this diagnosis. Okay. Here's the classification schema. There's somatic symptom disorder. There's illness anxiety disorder, formerly hypochondriasis, hypochondriacs. Conversion disorder, functional neurological symptom disorder, psychological factors affecting other medical conditions, that's a diagnosis. Factitious disorder, completely made up. Then there's other specified somatic symptom related disorders and unspecified. So again, like everything else we've seen, they always have grab bags of otherwise not specified. We'll put you down there. Okay. The common links in somatic symptom and related disorders, there's a prominence of somatic symptoms, so something about the body. My head hurts, my back hurts, my stomach hurts, I hurt all the time. And it causes significant distress and impairment. So you got to have body something with distress and impairment. Commonly encountered in primary care practices in other medical settings, but less commonly seen in psychiatric and mental health settings because they actually can float around in your practice and among practices, and they never go anywhere because you're just a failure. I've told him about my back for 3 years and nothing ever happened, and then they go somewhere else thinking you'd figured out. Okay. There's one other topic that we're going to talk about in this grouping. I told y'all about this the other day. There is a category of obsessive compulsive relating disorders. There's a syndrome called body dysmorphic syndrome, and I'm just going to put it here because with somatic complaints and body issues, I kind of like to hear better than I liked it over in the OCD section, so we'll look at it. So somatic symptom disorder. Okay, the patient has to have one or more symptoms that are distressing and result in disruption of daily life. So one or more symptoms. They have to have excessive thoughts, feelings, or behaviors related to that somatic symptom or associated healthcare concerns as manifested by at least one of the following. They have to have either persistent thoughts about it, they have to have persistently high levels of anxiety, or they have to spend excessive time and energy devoted to it. They don't have to have all of those. They just have to have a symptom that distresses them and messes their life up, so they say. And they can either have persistent thoughts about it without anxiety or time, or they could have high anxiety about it without saying that they think about it or spend excessive time on it. Or they could just spend a lot of time going to doctors all over creation but never really project anxiety or act as if they're thinking about it every day. It just bothers me. I just have an appointment. I have an appointment. I go over here and I do that. Usually you'll see more than one. Okay. Although one somatic symptom may not be continuously present, the state of being symptomatic is persistent. So it could be the back for 3 months, and then it's the stomach for 2 months, and then it's the headache, but there's some somatic thing going on for at least 6 months. It doesn't have to be the same one all the time. When you're coding this, and I've given you this on just a few of these, there's lots of coding modifiers and extenders that you can put onto them. This one I think is helpful. It can be, if it's with predominant pain, then you can do that. So it'd be somatic symptom disorder with prominent pain, or somatic symptom disorder persistent if have severe symptoms, marked impairment in long duration, more than 6 months. Or you can specify severity. It can be mild if they only have one symptom from criterion B, which is either thinking about it, having anxiety about it, or spending a lot of time on it. Or it could be moderate, 2 or more symptoms from that, spending time and being anxious, or severe, 2 or more symptoms from criteria B, plus there are multiple complaints. Head, back, and arms hurt all the time. Okay, and you code it like that. Okay, the somatic symptoms without medical explanation are not enough to make the diagnosis. Because some people have backache, but they don't act like it messes up. I mean, my back hurts all the time, but they go on. These people have the complaint all the time, and they suffer, and it's authentic, and they just are overwrought with things. Their symptoms are not fake, and you really have, this is a distinguishing criteria versus some of the other ones we'll look at. They have somatic symptoms that they will tell you about that persist for a long time, that they worry about and spend time on, and they are suffering because of it, disrupting their life, and they are not faking it. You might want to say, well, there's nothing there, you must be faking it, but to them it is not fake. It is a real thing. It's a mental disorder, but they're not faking it. There's other catch-alls for that. Patients often go expensive, time-consuming tests and ineffective treatments. You'll be a bad practitioner. They couldn't figure it out. That wouldn't go over there for anything. Those people are all stupid. You'll hear that. Get ready. You'll do a good job and they'll think you're terrible. They are unusually sensitive to medication side effects. Because they already have somatic problems, they're ready for anything to cause a problem in their body, and they will quickly accept things, and complain about it. They often feel their workup and treatment are not adequate. But don't we need to have this? Shouldn't I have another lab test? How come you don't x-ray this? It just goes on. Patients do not perceive themselves as psychiatrically disturbed and resist psychiatric referral. A lot of anxiety, depression as a real diagnosis is part of this, and it may be they have an increased risk for suicide. What causes it? Nobody knows. It's not known. But a lot of them come from chaotic, unstable, dysfunctional families. So there's already kind of a dysfunction that they have lived in all their lives. They may use the physical symptoms as a coping mechanism for attention. That's what some people think. If you grow up in a household where everybody's crazy all the time and it's just not normal, you can't really know what to expect, then sometimes they might actually gain something, or it's a way to deal with their chaos by just, here's the one thing that's always familiar, I can always expect a certain type of response from, so it is owned and possessed and mentally becomes part of who they are. It's diagnosed more often in women than men. It can be as high as 10 to 1. I was looking at the stats on this again earlier the week, and I saw everything from 2 to 1 or 3 to 1 up to 10 to 1. So women are more likely to do it, and it's because women are more likely to report somatic complaints than men. Because in Western culture, America, if men complain about every little ache and pain, then they're kind of a wimp, and that's just, you're supposed to tough it up, suck it up, get it on, what are you fussing about? And women have more permission to complain about body symptoms, just culturally. They are usually friendly with medical office staff. They're there all the time, they kind of know them, it's not a group of people. There is a patient health questionnaire that you can use to kind of screen for some of this. It's the PHQ. This is not the PHQ-9, which kind of limits to certain questions. This is kind of a wide open catch-all questionnaire that ranges across emotions, body, symptoms of all kinds. Okay, and I've got an example on here, and I've got a full one that I'll post on your D2L site. I don't expect you to know all of that stuff. Just know there is a PHQ that can screen 13 physical symptoms that are screened for. The possibility of somatic symptom disorder is considered when a person marks bothered a lot by at least 3 of the symptoms without an adequate medical explanation. And this is a very simplified version of what that screen looks like. Let's see, stomach pain, not at all, a little, a lot. Back pain, not at all, a little, a lot. Now, if somebody has a broken back because of a car wreck, that's not a somatic symptom disorder. But if they don't have any reason you can explain it, and they've got all these things that bother them a lot, then you might be looking at that. I will let you look at that PHQ that's been downloaded because it is a fairly full, extensive form, and it just shows you what it can look like if you wanted to use that. There are no specific findings as you'd expect. There's no cause for one. If you get abnormal lab tests, then you don't have that diagnosis. Neuroimaging studies have not been reported, you know, like all those scans we've been looking at, what's the brain do when you say you have this, they really haven't looked at it like that. The diagnosis that people usually get and talk to any primary care or healthcare provider, and these are the diagnoses that people just want to go screaming in the dark about. Fibromyalgia is one of them. Any of y'all here know about fibromyalgia? Okay, you know people who have it, and they're always in pain, and you cannot do anything about that pain. And they tend to get drug addicted because they are out there and they are looking for something, and it's so compelling. And it might, you know, maybe they really do have fibromyalgia. Some people really do have this disease, and y'all get that in musculoskeletal, and sometimes they really don't have that disease. And then in which case it might be somatic symptom disorder. Yeah.
How do you tell the difference, since fibromyalgia diagnosis is subjective anyway? And then you got your dependent, we just went over dependent personality disorder, like where?
I think it's a good question. His question is if you can't really do a good diagnostic test for fibromyalgia and you have people complaining, how do you actually figure it out? Maybe in fibromyalgia you'll get, you know, ESRs, you'll find inflammation that you should expect to see something at some times. But I think it's a really hard diagnosis to make. I really personally don't think it's an easy diagnosis to make. It'll just depend on, do you think, if you find any, what's that?
Then once someone gives them that diagnosis, they like hold on to it.
Yep, if you give somebody a fibromyalgia diagnosis, it's really hard to all of a sudden pull back and call that a somatic symptom disorder because they've had a diagnosis. As you will all find, medical practice and assessment and diagnosing is not a precise thing, and it is subjective in some regards, and it also is based on personal bias and even your relationship with the patient. It is not that simple, and it won't ever be that simple. Never has been. Another one, chronic fatigue syndrome, chronic pain syndrome, and then there's a thing called dysautonomia that you throw out there. Have y'all had that anywhere? I don't think y'all have had that anywhere. But basically it's just a disorder of the autonomic nervous system, and it can be diminished functioning or excessive functioning. So if you have excessive functioning to the autonomic nervous system that goes to your intestines, your stomach, you might come up with all kinds of body complaints that are GI related. So it's that type of a thing. Treatment approaches, you want to avoid statements like this is all in your head or there's nothing wrong with you, okay, because now you're confronting what they really hold as true and they're suffering. Only do diagnostic and therapeutic procedures if there is objective sign or symptom present. You'll get this hammered on top of you by insurance companies because if you don't really have anything that you can prove while you're doing stuff, they will eventually call you out. Because these folks always move beyond x-rays. They want CT scans, they want MRIs, they want these big expensive things. And some of them will get it because you don't know what you're dealing with, but until you start getting negative and then you don't know what to do with it. You can't just keep doing them. Have only one provider prescribe all the medications to coordinate medical care. If these people operate through a hodgepodge of people, their medicine list is going to look like that because everybody wants to give something else. That didn't work, that didn't work, that didn't work. I got sick on that, that made me sick. And then they go somewhere else and before you know it, it's this big, literally. A confrontational approach may lead the patient to shop for a new provider. You don't give them what they want, they're going somewhere else. And maybe if they've worn you out, that's okay. Okay, if they wear you out, maybe it's okay. They're high risk for iatrogenic complications like addiction to medications, surgical complications if they've gotten it exploratory. If people complain enough, they're going to have to go look. That can happen. Managing disease is aimed at reducing symptoms and containing cause, no cure, no evidence of reduced lifespan. Some providers will probably say, unfortunately, they're here for the duration. Okay, let's look at this. This is kind of interesting.
See, people misunderstand hypochondria. They think you're a hypochondriac, right? That's what you said. You think she's a hypochondriac. Family members have said that. And there's kind of a new term for that now. This is a somatic symptom disorder, and I want you to read this. Very high levels of worry about illness and tendency to appraise symptoms as unduly threatening, harmful, and often think the worst about their health. Also, one or more distressing and significantly disruptive somatic symptoms present. Okay? Now, let's think about that for just a second, okay? Take a look at that. Very high levels of worry about illness. So definitely true there, correct? And tendency to appraise symptoms as unduly threatening. Which means you tend to overinterpret or overreact to the symptoms, that you exaggerate them in some way, in your own mind.
No, I don't feel that. Okay,
well, often think the worst about their health. True? You think the worst about your health?
Over the last few years, yes, because I've gotten scary diagnoses.
And also one or more distressing and significantly disruptive somatic symptoms. So a physical symptom, one or more that is actually distressing to you. Like getting in the bathroom for instance. That would be a somatic symptom that would be distressing to you, right?
No, because it's just not normal. At my age, the doctors say that's
so
not normal.
So it seems that a lot of this would apply to you. The only thing that you would disagree with is that you overinterpret symptoms or think they're unduly threatening. Here are a few of the characteristics. Just want you to consider this. Distress or disruption of daily life due to one or more somatic symptoms. So is your daily life disrupted?
My whole life has been disrupted.
You said, I keep this room bright and cheery because I'm in here 15, 20 hours a day. Right? I live in this room. I even have my Hello Kitty microwave in here so I don't have to go into the kitchen to prepare meals.
Yeah, because too fatigued to even want to get out of my room.
Yeah, too fatigued to want to go here. Disproportionate and persistent thoughts about the seriousness of one's symptoms.
Yeah.
I want to check that one off. Or persistently high levels of anxiety about health or symptoms. Right? Excessive time and energy devoted to these symptoms or health concerns.
Yes.
You say you go to the doctors 4 or 5 days a week. You've got a box of pills that are huge. Take a lot of medications. Shamita has been prescribed over 80 medications. Over 80 medications. I don't wonder that.
I don't understand why these people are laughing.
They're laughing at it's a shock aspect. It's a shock aspect.
It's a shock to me. The doctors are the ones giving you these medications and saying you need to take these because you're sick, and if you don't take these, you're not going to get better.
Wow, that's a lot of medications. Well, and that kind of medication, taking that many different medications in that concentrated fashion across a period of time can definitely disrupt the homeostasis of your body. It can get you out of balance and make you sick. The current ones you're taking are on the screen now. So that's the list you gave us, and boy, that's a lot of medication to be taken, and some of them work at cross purposes. Some are up, some are down.
Well, that's our frustration, is who's talking to who? Is she being honest with all the doctors? Like, this does not seem normal.
And there's a second piece. We're going to finish this out. Okay, now hear the rest of this. It really gets cooking on the second one.
I just think that I look ridiculous on the taping. It just makes me look like a crazy person. I mean, I don't know. And my daughter being so brash. I mean, it doesn't sound like it's coming from a sincere place.
If you can get your life back, if you can get out of that room 15 or 20 hours a day, if you can get back to jogging around a track, going to movies, hanging out with friends, doing things with your children, Would you rather do that, or would you rather be a patient?
I would love to do that. I mean, that's what I'm really surprised. Sage's the only one that at least I tried. I really saw bits of Ashton. He told me that he supported me on the take.
And Dr. Felton can help with her on that, because she's told me within the last 2 to 3 years, she says, I hate what this has done to us. I hate what this has done to our family. I hate having to go to another doctor's appointment. So I genuinely believe those are true ways that she feels. She just doesn't know how to get there.
But you know, Owen, people on heroin tell me they hate being addicted.
True.
But they will step over their mother's dead body to get to the next fix.
Absolutely.
They'll tell you they hate it. They hate being a slave to it, but they can't stop.
Right.
And this woman is addicted to being sick. This woman is addicted to doctors. She's addicted to the attention that comes from being a patient. I'm telling you, and you can think, you can shake your head and shake me off if you want to, but you have gotten to the point that you've lost control of this, and she doesn't have insight to it. We've got to get that back. We've got to get her back where she sees this objectively. And I'll give you an example. Would you agree that she talks about and focuses on this?
Oh, absolutely. If that's what you're living, of course, absolutely.
Well, but it's what you're living. If you're, it's like a dog chasing its tail.
Right.
You say, well, of course she focuses on it because it's what she's living. And it's what she's living because she's focused on it. And she's focused on it because it's what she's living. It's what she's living because she's focused on it. It goes around and around and around, but pretty soon you start to circle the drain and it goes down. You've got to break out of that cycle. Does that mean she's not sick? Of course, but there are people that are way sicker than her that go on with their lives and do what they're doing. And that's what we have to get to here. That has to be the goal.
So you see, it is more sticky than you might know. If any of you have taken care of patients, you know folks like that. She was kind of interesting to me because she actually had kind of something about, I mean, the way she's made up. She's overly made up, her hair's overly done, she had rings all over her fingers. There was a lot of attention stuff built into just her presentation of herself. I'm not trying to be mean or act ugly, but I mean, she doesn't, I mean, that's an exaggerated presentation of self. Yeah.
Again, how do you tell the difference between the tendency and the somatic? And there's a lot of stuff going on there.
Yeah, there is a lot going on there. They have narrowed it out. He's asking a good question. How do you figure this out from dependent personality disorder? She could actually be diagnosed with somatic symptom disorder and a dependent personality disorder.
Well, then with the looks and stuff, if I'm just like imagining reading this question, I mean, I see this person, yeah, sure, you're going to address them well, but
I'm not going to mess you up that way. I guarantee you I will not mess you up. I have given you, I usually have pretty much in what I've done, highlight and bold the big features. And I'm not going to try to make you sort through people who are ambiguous to try to call it. If I end up in intention writing an ambiguous question, it will show up in the way people respond. So don't worry about me. If you know the big main distinguishing features, the little scenario clips will be so heavy in that direction that there will be no way to go about that way.
And then the other question I have is like, so she's on that list of medications prescribed by multiple providers.
Yeah.
How do you go about treating something?
That's a good question. How do you go about treating something like that when you have a list like this long? It takes a long time. I have had, it's literally, I had a patient referred to me one time. He used to have a good number referred like this, and you end up with a group of folks somewhat like that. They're on chunk of medicines. Person was on 27 different chronic medications. And the provider said, I don't know what to do, but can you help me get this person off of so much medication? I said, well, I'll have to talk to him about everything. So you have to go over everything. What are these things for? So I went through the list of every single thing, evaluated was there a diagnosis and what was the outcome expected, how was it functioning, just all of this stuff. Not one medicine was that person willing to give up. Not one. Because they all have a subjective quality in their assessment. You know, do you feel better, whatever. So then it's like, okay, this person is on 27 things and they want to stay on 27 things. They don't want to come off. We need to go to psychiatry. I mean, you start looking at what are you going to do with that person. They obviously were attached to all of them. I remember putting them down and saying, okay, well, we can move this. No. It's like, okay. There's something else going on. This is not a real intention to get on less medicine. There was an intention to stay sick. Okay? These are tough people.
I've seen it so many times. I've never known what to do with it. I mean, literally, it's hard to refer people to psychiatry.
Do you know?
And it's a really tricky issue.
He's making excellent points as a practitioner. This is not, you're not going to have 30 out of 30 who have this, but you're going to have 1 or 2 out of every batch that will kind of come across somewhat like this. And I think that the job is always to focus on issues, work it up from a medical perspective, not to overdo, do what is called for by results. And if it does not meet satisfaction, then it may be that this person is not going to work with you, and then there they are. You could always say, you know, sometimes when individuals come to this point and we've worked things up and it doesn't turn out to be something physical, sometimes it's the way our mind and our body work together to create a situation that's acceptable for right now based on all the circumstances that have led up to now. Didn't say you're mentally ill, didn't say it's a psych disorder. Sometimes the mind and body do things like this. Sometimes they might kind of get there, how do we treat that? It's like, no, we're not there. But you can start leaning that way, and then depending on their responses, you can either lean further into that direction or you can just kind of back up and just kind of go, we're going to have to get out of here. And then you know you are walking into the bad zone, the endless zone. Okay? It's a good question. These good questions. And I know in chiropractic you see a lot of this. You'll get people who've been everywhere else and they'll go there. It's like, okay, now what do? You don't know. I'm going to give y'all a 10-minute break because it kind of went along a little bit. So let's just walk around for 10 minutes and we'll come back and we'll look at hypochondria.